Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. J. Calvert, today here with my most circumferential and vertical co-host at the same time, Dr. Millicent Rovelo.
Good evening.
Did you know you could be circumferential and vertical at the
and
same
vertical.
time?
I did not, because I've always been rather vertically challenged. I didn't realize that was an option for me.
You could be circumferential.
I am circumferential.
Well, and I am not a fan of the circumferential, periareal, or mastopexy, which is what we're talking about today.
And I am so excited to be talking about this because, as I think we all are, we get very frustrated by this topic, and we just need to clear the air about what is and what is not possible with mastopexies, with breast lifts, because this is a tough one. It's really tough because usually what the patients want is not what they need.
If by the end of this podcast we're throwing things and it's like smashing furniture, everybody just needs to forgive us, because it is very frustrating. This is one of those topics that we just go, no, that can't happen. That's not possible.
No, it's not a thing.
It's not a thing, and it's not going to happen.
But I get it. I sympathize, because what we're talking about are the scars on a breast. And this is for patients that come in for a breast lift, either with or without an augmentation or an implant at the same time.
Yeah, and that's the thing. It's like there are a lot of ways to make a beautiful breast. And some of the techniques that are popular, because they're certainly marketed that way, are not exactly effective at making beautiful breasts.
No, they are not. And the issue always comes down to the scars, because nobody wants to have a scar on the breast, obviously.
No, definitely not.
But there is really no good way of lifting breast tissue, of raising a nipple from its position down on the chest to a higher position on the chest, other than by making a scar. And when we're talking about lifting a breast, and this is whether you are doing it on its own, or whether you are doing it with fat grafting, or whether you're doing it with an implant, if you are talking about lifting a breast, there are really three surgical techniques or scar patterns that you can do. One is called the periareolar, sometimes referred to as a donut lift.
Boo.
Boo.
We don't like that one.
You could also...
We do it, but reluctantly,
really
and we're going to talk about why and when.
Actually, no, I'm going to take that back. There's 4, because before you get to the donut, there's a crescent lift.
Boo.
Big
Can I boo that
boo.
one even more?
Yeah, that's a big boo.
I know, but I wind up doing these things. And then the patients are like, oh, I don't like the scar. I don't like doing it. I'm like,
Save it.
Yeah,
Save it. We're going to get to it.
Right.
Let me do my spiel.
No, I'm not going to throw anything.
So number 1, crescent. Number 2, periareolar or donut. Number 3 is called a vertical. Vertical is, yay!
We like the vertical.
Vertical is an incision that goes around the areola and down the center of the breast. So otherwise called a lollipop scar, because that's what it looks like. Or number 4, I guess we could call it wise pattern or anchor, or depending on the length of it, an owl with feet, I've heard it described as. If you look at
those are some big feet if you're going all the way across.
Look at the little feet. Yeah. But basically, it's the incision around the areola, down the center like the lollipop, and then under the width of the breast. So
in the fold.
In the fold. And honestly, the difference between a vertical and an anchor pattern is really not that big a deal, because you're never going to see the scar under the breast. It's not a big deal at all. That scar, though, is sometimes necessary if you have a very large or very droopy breast. You need that extra incision to get all the extra stuff out. But in terms of the overall aesthetic, it doesn't really change anything, because it's not a scar that you're actually going to see.
It's true. And the vertical component is the objectionable part to the patient, and it's also the key for us to make a beautiful breast.
So it's like kind of a conundrum. But let's start at the beginning, because let's go back to this crescent incision.
Do we have to?
I wish we did not. I just saw a patient last week who had a crescent incision mastopexy, and she now hates her scar, because here's why. A crescent is exactly like it sounds. You're basically just removing a little bit of skin at the top part of the areola from like 9 o'clock to 3 o'clock. And so the idea is that you're pulling up the areola just a little bit. A lot of times it's used in combination, like if you have one nipple that sits maybe a little bit lower than the other side.
Yes.
And so you just want to like pull up one side a little bit. This would be an option. The problem is with how the areola heals. The areola is the thinnest, most stretchy skin on your breast. And when it scars, it stretches.
Sure
and
does.
if you only have a scar sitting on the top part of the areola, when it heals and it stretches, your areola has now gone from a circle to an oval that's long and it looks like it's stretched out. And it is not a cute shape. It's not cute at all.
Boo. I'm telling you, I'm going to boo that technique.
It is awful. I hate that one.
I wind up doing it though, because like you said, in a little like augmentation where there's a little discrepancy, like the nipple areolar complexes are at like 21 centimeters on one side and like 22 and a half on the other. It's like, just a little crescent.
It sounds like it makes it. Just pull it up a little bit.
And by the way, it works. So it does work.
It works,
but
it leaves kind of a
awesome.
funny shaped areola. Sometimes.
Yeah. It depends how aggressive you
how
are.
much you have to lift it.
And if you need to lift a lot, then you shouldn't do that.
Then you shouldn't do
technique.
it. The other option, if you're just trying to lift it a little bit, which is what I sort of lean towards, I'm like, look, I only have to go up like a centimeter. But I would rather just make an incision all the way around the areola and lift it up as a unit as opposed to just trying to stretch out the top half. Because now, even though the incision goes all the way around, when it heals and when it scars, it heals concentrically in a circle. It doesn't stretch out into some weird shape. That's probably the only time I would actually endorse doing a periareolar lift. If you have one side that's a little asymmetric, or if you really only have to move that areola up by like a centimeter or centimeter and a half at most. Because other than that, it's not really a good lifting technique. It's a good kind of like symmetrizing technique.
Yeah.
So I know why I hate the periareolar. Why do you hate the periareolar so much?
The scars. The scars are never great. They just aren't. They're always like, you wind up taking. So, by the way, there's a hilarious episode of Tyra Banks that I'm on where the producers tried to use fruit to demonstrate what a periareolar mastopexy was. It just was a train wreck. Like, no matter what they did, I was like, nope, that's not it.
Nope, that's not.
And so
how
ultimately,
it works.
Tyra and I were like, what are you guys doing? So she does this thing where she's like showing like an orange and then she has like a kiwi on top of it. And she's like, so you're taking this orange and trying to make it a kiwi. I was like, yeah, that's not quite the idea, but it kind of is, because you're taking an incision that's the size of, say, a grapefruit, because you'd have to take all that skin out from around the kiwi. And then you have to take that grapefruit-sized circle and squeeze it down around the kiwi-sized circle.
To make it a normal-sized areola.
Right, and that's what the producers were trying to get at, was that you have to take a big circle to make it small. And so the scars, somewhere that gap of that giant circle being made to a small circle is going to make crinkle-cut potato chip style scars.
Right. It puckers all the way around.
All the way around.
And so that's why this technique is not supposed to be used for anything more than a tiny lift.
A centimeter,
a
maybe.
centimeter and a
half.
half. When you try and do more than that, again, this is a complete concentric circle. So if you have to get that nipple to go from 26 centimeters to 21 centimeters, that's a 5 centimeter difference. Well, you have to take 5 centimeters above the nipple and 5 centimeters below it, because you want it to heal as a circle. You can't make it an oval. We just discussed that. So now you have a 10 centimeter diameter excision of skin that you are now trying to close down to a 4 centimeter diameter. And so you can imagine, any of our seamstresses out there, how that's going to pucker and pleat the skin as it's healed. So that is where the scarring can get really ugly, because those little puckers all turn into hard, thick areas of scar tissue. And the other problem when you're trying, this is where you're kind of getting into some geometry here, when you're trying to make a breast, which is sort of a spherical shaped object, when you now cut out the top part of it, 10 centimeter circle out of the front, and try and squeeze it down and crunch it down into a small little incision, it flattens the breast. It goes from being a nice, spherical orb that has projection and comes out in space to being squished and pancaked and flattened because you're trying to squish all the skin into a small little incision. And that's the problem with the periareolar. It leaves a really bad scar at the end of the day, and it flattens the breast. And most of the time, women don't want flat breasts. They want projected breasts.
Right, because that flattening is for real.
It is, and it just is not what a breast is supposed to look like.
No, a flat top breast is not what you're looking
Said
for.
no one ever. I want that.
Yet I wind up doing these a little too often.
Because patients they can't get over the fact that they may have to have an extra scar on the breast, and all they can think about, well, if it's just around the areola, then it's hidden, right?
Yeah, but I mean, that vertical scar is not, okay, it's not great.
So let's talk about why we like the vertical scar. Why are we like, yay, vertical scars? Why are we so happy to put a scar straight down the center of the breast?
It's because it projects the breast. It projects it. It cones the breast.
Nicely.
It makes the breast the right shape.
Now think about your pancake breast or your droopy breast, and imagine cutting an incision or a wedge of skin and fat right out of the center and then closing it right back up. All of a sudden it just goes whoop, and it closes it and it tightens it and it pushes everything up to the top.
And it does make that sound when that happens.
It does. It really does. It goes
whoop.
And the whole room goes, ah!
It's true. I know. It's weird. People didn't know that breasts make sounds like that, but they do in the OR. And it looks great.
It looks so good.
It's so much better. And
Yeah.
if you were to, that may be reason enough to get that imaging program.
True.
Just so I never have to do another periareolar lift. Oh, let me show you your breast with a periareolar. Here's your flattened pancake breast. And then, oh, here it is with the vertical scar. Oh. And your breasts will sing. I promise. They will. They will sing to you when you get out of the shower and you're like, I love my breasts. And they'll go, oh.
It is so, so true. That vertical scar.
It is that dramatic, though. It is.
So key to getting a nice, projected, beautifully shaped breast. Yes, at the cost of a scar.
Downside scar.
Downside scar.
Scars can be bad.
They can be bad. Although I will say that vertical scar, these are the problems I've seen with the vertical scar. A little bit of whitening, which usually isn't too bad. And in my darker skinned Asian or Hispanic patients, some hyperpigmentation around the scar. Very rarely do I see it keloid or hypertrophic. It just doesn't seem to do it in that area.
Well,
you know where I've seen keloids? Around the areola.
Yeah, I've seen that too, and that's because they're under tension.
So much tension.
Right.
Yeah.
But I've seen I have a patient now that I am injecting her ripping keloids on her vertical scar, and I don't know why she got them. It's so weird, and she doesn't either, and she's young and healthy and otherwise, but and she had them done by a surgeon who's really good, and just.
That's how she
So
healed.
it happens. So that's the
Yes.
downside is the scar.
It's
We
the
can't
scar.
sit here and just say, just sign up and it's going to be great. You have to know the risks of the procedures. That's why we do this podcast.
Yeah.
For information, so that the patient can sit there and say, okay, I get it. These are the things that but I really want to go this direction, and what are the odds? And we can give you the odds and tell you, but complications do happen. They do. The reason we're talking about them is because they happen.
Because they definitely happen.
And they happen to somebody. And they happen to somebody that it can totally be you, and it can totally be me, and it can be anybody. And so you have to kind of understand, like, okay, well, I'll have to deal with that if that comes up.
Right. Which is, again, why some people do tend to go the periareolar route. But also, those scars can be raised.
They can suck.
And be really awful. And they can spread. And it can be bad. And the thing about adding the vertical limb, not only does it project the breast and give it a really nice shape, is it takes the tension off of that periareolar scar. So if you're trying to lift a large amount and take away a lot of skin to lift the breast up through just a single donut scar, there's a lot of tension on that closure because it's just, you're asking that incision to do so much. If you just offset the tension by adding an additional scar down the center, all of that tension is taken off of the areola, and you can usually get a little bit better closure and less tension all around on all of your scars. So that is the benefit of the vertical scar. Again,
Well, and the shape.
well, yeah, the scar.
I mean, the shape.
The shape
do
is
you want your breast to sing or not? That's what this comes down to. Like, I mean, if you want singing breasts, then you're going
you
to
have to have the vertical scar.
Because the vertical scar makes the shape so much nicer. It is not even, it's a non-discussion point.
Yes.
Periareolar, no. Vertical scar, yes.
Yes.
It's real. And the anchor scar, the wise pattern anchor scar, owl with feet, whatever you want to call it, that additional part in the inframammary fold is sort of irrelevant.
It really is. It's done when necessary to, take away extra skin and tissue. Usually when you really have a large breast or a really low sitting breast, you need to offload all of that lower stuff on the breast. And the downside of having the bigger scar is that not uncommonly, there's a little bit of wound breakdown at that T-junction. So where your vertical scar meets the horizontal, that's called the T-junction. Around week 2 or 3, you may have a little bit of a wound healing issue, but it's minor. A couple of weeks of some antibiotic ointment on that little area and it heals. And you know what? No one even sees it because the breast sits over it. Like it could be a 3-centimeter incision and no one would see it.
Yeah.
Like those things, they just give it a little bit of time and they heal.
And these are all the factors that allow you to make a really beautiful breast. And so that's why, I guess, I don't know how I get talked into doing periareolar so often.
I don't know, but you do a decent amount of them. We just talked about this. You're too nice. You're too nice. I'm just like, no, we're not doing that.
I know, but it's like,
So here's a question for someone who does a lot of periareolar lifts. Now we're getting a little technical, but what is your closure procedure of choice in terms of your sutures?
So I used to use all long-acting absorbables like PDS, and that just made too much thick scar because they hung around too long. So now what I do is I do some long-acting PDS sutures for the deepest layers. Some, not a lot. Mostly it's monochrome, which for Tracy in Wisconsin goes away in about 2 to 3 weeks. I don't use a permanent suture around the areola. I don't do the Gore-Tex suture or anything like that. I think that ultimately winds up getting taken out, and I'm not sure that it prevents any stretching. But I do use a PDS to go around to do the periareolar subcuticular stitch.
Okay.
Which I don't think you need to. If it's under tension, I do, and if it's not under a lot of tension, if it's a small little lift, I'll use monochrome. But I don't use permanents. I don't use pullouts. I don't baseball stitch it, on the outside, which one of my very, very good friends who does a lot of breast does. 3/0 nylon all the way around. I know, that's the Lionel Richie suture. The 3/0 nylon.
Yeah.
Yeah, so we try not to do that on a breast.
Yeah. I'm a fan of the permanent.
Really? Do you use the Gore-Tex?
I don't use Gore-Tex. I used to use Gore-Tex, but I had problems with some of them coming through the skin or popping out, and I just didn't want to deal with it. So I don't use the Gore-Tex. Gore-Tex is a kind of, it's a big suture. It's a real thick suture.
They make jackets out of it.
Basically. But I like the permanent because I think that it prevents the spreading of the areola. So as we talked about, the areola is thin, elastic.
Do you use Proline or?
I use Proline. So I just do a whatchamacallit?
Running subcuticular Proline?
No, not a running subcuticular. I'm totally blanking on the name of how I do it. It's not the wagon wheel. It's not the mattress. It's a purse string. Duh.
Oh, purse string.
Purses, Rovelo. It's your thing. Purses.
So you do a purse string,
I do a
permanent
purse string
suture
around the outer circumference
and that's staying in, or are you going to remove it? Stays in.
So I do a purse string on the outer circumference of the areola. I cinch it down to the size that I want it to be.
Yep.
And then that's it. And then I just do a superficial running subcuticular just to bring the edges of the two circles together. And that works. That seems to prevent the spreading of the areola. And because it is a proline, I think I use a 2O proline, it just doesn't seem to... Yeah, 2O. I mean,
that's
it's
legit.
probably a 3O. It's probably a 3O proline. 2 is too thick. It's the 3O proline. I haven't had any problems with it coming through the skin. Although one time I did take a patient back and I had done that on her. I did a 3O proline and I had to take her back for some other reason to swap out an implant or to do something. And I didn't reclose the proline suture. I was like, oh, it's been like a year. I don't need to retighten this proline. So I just kind of cut it and closed it with monochrome. And guess what? That areola went poof, and now it's like twice the size of the opposite one that
Maybe
held
I'll try
it.
that then, like a deep proline. I'll try it. That sounds like a good idea. That doesn't prevent me from doing everything else the way I do it, and it might be a good support for the deep tissue.
For all those periareolars that you're doing.
I'm gonna try not to do any of those again if I can help it. All right. Well, that sounds good. I like it. Speaking of 3O nylon, so yesterday we were fixing a hernia. Mm-hmm. You'll like this. This is a good little aside. Mm-hmm. So we're fixing a hernia, and and I think I said something like, "Oh, I'll take an O proline," and the nurse goes, 6O proline. I was like, "Yeah, no, I'll take a 6O proline for the hernia repair." Now, for Tracy in Wisconsin, a 6O proline, you can't see it. It's so fine.
We use
Unless
it for
you really look. I use it to close the columella and
yeah.
use it for eyelids. And so I go, no, an O proline. And then so I started, of course, making jokes because it was funny. And I started going like, oh, yeah, it's just a very dainty, it's a dainty little, very umbilical hernia. Just give me a 6O proline. Let's just whip that up with a little 6O proline. This is not a joke. So we go to close finally the hernia is isolated and we're working away with, getting it all set up. And I was like, all right, give me the stitch. What do you think they handed me?
A 6O proline.
The 6O proline. I swear to God. I was like, didn't you guys get that was a joke? I can't close this with a 6O proline. It was hilarious.
You know the only people who thinks that this is hilarious?
Us.
And our fellow plastic surgeons. Everyone else is like, you guys are lame.
You guys are dorks.
You guys don't really understand what a joke is, do you?
No. But I will tell you this. On one of my favorite podcasts, Smartless, Mike Myers was a guest just recently. And he said that one thing that he really loves are running jokes. And that is totally like our OR and
the
our
OR
whole
is
practice.
Our OR is one.
It is a running joke. Like there are running jokes, and he was telling the story about he and Dana Carvey doing like the Beatles being totally filthy and like talking about like nasty stuff together, and so like anytime they want to get it started, like he said they'll like finish a skit, the audience will be applauding, they'll be on stage, and Dana Carvey will just break into like the John Lennon like. This one time when I was in Liverpool, like, and he will just lose it. Like he'll go from like, loving the moment to just like crack because they do this joke going on.
Yeah.
Like, and he says, I love running jokes. And I was like, so do we. That's kind of our thing. We love a good running joke. So I think the 6O proline for the hernia repair has now entered. Like the 3O nylon, it's like.
Yeah, the Lionel Richie.
It's just, it's fun, you have to have those things that keep your kind of the fun aspect of what we're doing. And I love what we do. It's really fun. And, we pay attention to every little detail. So when somebody says, here's your 6O proline to fix the hernia, I'm like, that was a joke, by the way, in case anybody didn't know. But I was like, oh, thank you. Perfect.
That's what I needed.
Well, that's it. I think we kind of hit it on all aspects of these periareolar mastopexies, which I will try to do less of. How can I do less of them, though?
Gotta be mean.
I just gotta
say no. Just say no to the periareolars.
Do I have to be mean?
You do.
I'm not mean that way though.
Oh, can I tell you my story about the one time I actually did do a periareolar on purpose?
Sure.
I mean, they're always on purpose, but when I intentionally was
you said I'm going to do this.
This is what I'm going to do,
idea.
And I do not hate this idea, is for a lady that came in, she needed a lift, but she wanted implants because she had previously had implants, and without them she was very deflated. And so she's like, I know I need implants, but I don't want to look like I have implants in. I want to have a very natural look, but I don't want to actually look natural. I want to have like a natural B cup. Like the natural B cup with implants. Really hard because implants just aren't made to look like natural B cup breasts. Oh, I guess they do make some pretty flat ones, but those just aren't that cute. No. But she needed a lift because her nipples were kind of hanging low. So I did intentionally do a perioreolar lift on her because it flattened the breast.
And that's what you wanted.
And that's what she wanted. I tried to do a vertical, and that pushed the breast up nice and high, and it had this pretty superior pole fullness. And I was like, oh, it's so pretty. She's going to hate it. So
you got to give the people what they want.
We went back to the perioreolar, and it flattened the breast, and it kind of made it a little pancakey, but natural and swingy, and she loved it.
There you go.
She loved it.
So that does have a purpose.
Is when I would intentionally use a perioreolar. I will be kicking and screaming, but I will do it.
Well, I think there you have it. You've got all the options. So for our listeners, do not be disappointed when we say you really need to have that vertical mastopexy. You need that vertical limb. Otherwise, you will not have the breast that you're looking for.
Unless you do want them flat, in which case you will.
That's right. There you go. Well, so this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210 in the flats of Beverly Hills.